This is Dr. Stone-Gale, and this is going to be a mini lecture on conjunctivitis. All forms of conjunctivitis, including bacterial, viral, allergic, and all other types, involve inflammation of the transparent mucous membrane, such as called the conjunctiva, and infectious causes of an inflamed eye and conjunctivitis include bacteria. There could be viruses, there could be fungi. But so the phrase pink eye is usually referring to conjunctivitis, whatever kind it is. It doesn't matter which kind it is. Some of the causes of viral and bacterial and allergic and non-allergic conjunctivitis are some of the risks of getting pink eye usually increase if somebody else has it and you're around them. So if somebody's at work with pink eye, if you work in a daycare, people who work in daycares are known to get pink eye. They are always coming in the office, and the first thing I always ask them is, do you work in a daycare? Do you work around children? Are you a teacher? Because those are the biggies. Children give pink eye to everybody. So exposure to someone infected is a big one, as well as rubbing the eyes, and then you have bacteria on your hands, and you transfer that bacteria to the eyes, and you'll transfer it to contact lenses if you don't clean your contact lenses before you put them in. The allergic is usually because, as I said, that allergy, that exposure to that allergen. So the pollen, the grass, the weeds, the dust, mold, that type of thing. And chemical, we talked about the risks of that with, being around, any type of source that can cause you to have eye irritation. And then contact lenses is another one. So some of the signs and symptoms that you're going to see, regardless of the type, is you're going to see some type of a discharge, whether it's watery or purulent. You're going to see some marked diffuse redness, and that's going to be with any type of conjunctivitis that you see. The bacterial conjunctivitis usually has that mucopurulent discharge and usually occurs in one eye without any type of preauricular adenopathy. The eyelids do have a thick crusting on them, and usually you wake up in the morning and you have one of your eyelids is closed tight, it's matted shut, the eyelid's swollen, and you have to do really warm soap and water, like a baby shampoo and water soap, to even get your eye open. When you're looking at the viral type of conjunctivitis, this is where you see more of a purulent discharge. It's more of a liquidy, a watery, and it usually goes into one eye and it can spread very quickly to the other eye. This is where you see the preauricular adenopathy with this. And it may be associated with fever, and you could have that pharyngitis, because remember, this is something that has involvement with an upper respiratory infection or the flu, something like that. So it is definitely highly contagious. When you get into the allergic one, usually you'll see some itching and tearing, and that's one of the biggest things, that you'll see itching, tearing, and the redness in the eye. And that is something that really causes uncomfortableness to the patient. So this is these are some pictures of conjunctivitis, excuse me. You can see the normal, and then you can see the inflamed. You can see how the sclera and the conjunctiva are very irritated and inflamed in all of these pictures. But the key difference is here, if you look at the bacterial versus the viral, you don't see any mucopurulence in the viral. You only see it in the bacterial. So you see in this, how the eyelashes are matted shut, the mucus actually is stuck to the eyelashes, and they get that periorbital inflammation. And then this is chlamydial and hyperacute bacterial. Now, you probably are not going to see this in primary care because you're not working with infants, and this isn't a peds course, but I just wanted to actually bring this to your attention so you could see how it would look in a newborn. And this is allergic. There's a lot of periorbital swelling, there's a lot of erythema, there's a lot of conjunctival and scleral injection. So what are we going to ask the patients in regards to history? If they come in with this condition and you suspect that they have a conjunctivitis, there's specific things that you need to ask them in order to differentiate if it's bacterial or if it's viral or if it's allergic or non-allergic. So the onset, when did it occur? How long have you had it? Is it acute, chronic, recurrent? What does the discharge look like? If they tell you it's very watery and my eyes are itching, then you could probably go towards viral. If they tell you I have like a yellowish, greenish discharge coming out of my eyes and my eyelids are matted shut and, it's only in one eye, then you can pretty much assure that it's most likely a bacterial. If they tell you they're just having itching in their eyes and their eyes are red, then it could be just the allergic type. So actually getting all that information is going to hone you in. And this is when you do your HPIs, is where you pull all that information out of the patient so you can try to get a good picture. Doing the review of systems with this would be asking them about history of allergy, history of eye trauma. Have you been around anybody that's had anything? Have you been around, in the HPI would be, have you been around anybody that's had any discharge? Do you work in a daycare? That type of thing. For the review of systems, contact lens use would be another one, as well as, asking them if this is something that they've had over and over again. In the physical examination, as with all of the eye things, it would be, priority to assess their visual acuity. And your eye exams are the same pretty much in all of the, different disorders of the eye. So you're going to do a complete eye exam with, inspecting and palpating and inverting the eyelid and looking at the sclera, looking at the conjunctiva, looking at the amount of discharge and what color it is, and looking for that pre-auricular enlargement, which you are going to see with viral conjunctivitis and not with any other type of conjunctivitis. So that's another key thing to look at when you're doing your physical exam. And that'll give you an idea of whether it is one versus the other. So now we're looking at treatment. And with the viral, you really can only do symptomatic relief. This is a self-limiting condition, and usually it clears within 2 to 3 weeks. These patients just need to be reassured. They need to be using artificial tears and cool compresses and understanding that they might spread this to others, so being very cautious about that. Antihistamines. Remember, this is a viral origin, so it's coming from an upper respiratory infection. It's coming from the flu. It's coming from some other condition that they have. So antibiotics are not going to be used for this. So the patient's going to have to be told this, and they're going to come in and know they have conjunctivitis, and right away they need to have an antibiotic because they know that's the only thing that's going to cure it, and I have to go home and I have to go back to work and I have kids. And so these are some of the things where you have to do a lot of teaching with making them understand if it's viral. With bacterial, there are 4 different antibiotics that really work very well in mild cases: the erythromycin, the polytrim, the sodium sulfacetamide, as well as bacitracin. But when you get into more of a severe case of it, where they really are having a lot of symptoms, the Zymar, the Vigamox, the gentamicin, those are the big guns that we go ahead and use. And but we hold them for the big guns. We don't use them for just these mild and moderate cases. And they also need to understand with this that, it's going to take some time for it to resolve. When you get into the treatment for this, the seasonal allergic rhinitis, then, the over-the-counter antihistamines, the cool compresses, are very soothing, and they may need to also have, it could be that they may need to have some type of a steroid therapy if they are really uncomfortable. So this is the end of the treatment section, and we'll move on to the differential diagnosis. And then we look at our differential diagnoses. As you go into the room, some of the things you're going to be thinking about is, what could this be? What else could this be on this patient? What am I thinking? And you're thinking, could it be glaucoma? Highly unlikely. Could it be uveitis? Usually you don't see a lot of discharge with that. Could it be an obstruction in the lacrimal duct? It could be. But if they have a lot of mucopurulence, you're going to rule that out. Blepharitis, you're going to probably rule that out. Corneal abrasion, if they didn't have anything get in their eye and they tell you they don't remember anything getting in their eye, most likely it's not a corneal abrasion. Looking at keratitis and scleritis, those probably you'll rule out pretty quickly, but there's still things you have to have in the back of your mind that you're thinking, could this be something else? So this concludes bacterial conjunctivitis. I think that this is probably one of the most common things you're going to see in primary care because people have a tendency to come in immediately when they do see this. An ophthalmology referral would really be the best thing to do if you do see a severe case of conjunctivitis, bacterial conjunctivitis, or if you see that they're really just not improving in spite of the treatment that you're giving them with the self-limiting treatment or with the bacterial treatment.